Welcome to the Fujifilm Sonosite webinar on the Diagnostic Shoulder Series. This is part 1 on the anterior shoulder. Join us for the future webinars coming up later next week, and then 2 more in January on the lateral shoulder, the posterior shoulder, and the superior shoulder, which is a short subject, and that's where we're going to do a recap of the entire shoulder protocol and also take questions live on all of these. Tonight we're going to do a recap of the anterior shoulder, including the biceps tendon, subscapularis, dynamic maneuvers, and some probe handling tips and tricks, along with some patient positioning considerations. We hope you enjoy this tonight. Feel free to chat in the Zoom portal. As long as your questions are coming through the Zoom portal, even though we are attempting to do live in other streaming sources, your Zoom questions should come through really nice in the Zoom Q&A portal. So feel free to type those questions in. We typically get to the questions at the end of the webinar, and we'll field those live with live scanning. So we'll have a model here and be demonstrating the same thing to answer your questions if necessary. Also, anything about the machine, here is the Sonosite PX and its software. We hope you enjoy this, and we're going to go ahead and move over to the webinar. Thank you. Again, my name is Daniel Shelton. I'm the director here at Fujifilm Sonosite of MSK Market Development. Today's topic is the anterior shoulder, and specifically we're going to be discussing the biceps tendon and the subscapularis tendon. Before we get started, we should talk about some of the artifacts associated, especially around the shoulder, which is angle artifact. This is a loss, this anisotropy is a loss of reflectivity to the transducer due to off-perpendicular incident sound beam angle. Normal tendon appearance depends upon incident angle of the ultrasound beam being perpendicular to the tendon. This can be a potential pitfall. This can mimic focal areas of tendon injury, and it can reduce or prevent visualization or intra or peritendinous pathology. So here's an animation of the anisotropic artifact in motion, and you can see the tilting transducer is sliding up and down the biceps in a pivoting motion. So basically we're angling, and we'll do this in the live demonstration to really drive this point home. But look at the biceps groove as a bony landmark, and the biceps tendon isolated here is turning dark versus the surrounding contents that are less angle dependent, such as a little bit of fat, a little perivascular architecture here underneath this transverse humeral ligament, not so affected as the one that is popping in and out of perpendicularity here. So if we're slicing these tendons at 90 degrees, we get really nice views of the tendon. If we're off perpendicular, we see the tendon disappear in a healthy, normal tendon. I will say scar tissue will remain reflective because it's just a backfilling of collagen fibers in an unorganized manner. So anisotropy is also primarily dependent on the fibers being longitudinally arranged, linear striated in architecture, not just any collagen fibers. If it's more of a mesh like fascia, where the fibers are going in all directions, then basically we still see the fibers because we're cutting any direction of those fibers perpendicular. But in this case, when we're isolating a tendon, we're noticing that just that tendon falls off in perpendicularity and the surrounding structures remain. We're going to begin at the anterior shoulder. We're going to cut the shoulder in an axial body plane, and we're going to locate this hyperechoic cortical surface of the humerus. If you're not seeing a sharp cortex, that means the rest of the structures on top of the shoulder are not going to be very sharp. So start with your bony landmark as a reference first. If you're not seeing sharp cortex, work on your angle to prevent that anisotropic artifact. We should say on the lateral side of the groove, just as a just an FYI, there is a normal vascular landmark. Is this ascending branch of the circumflex humeral artery that climbs up the biceps groove, just parallel to the biceps, starting at about the surgical neck. and then it follows the biceps and inserts into the lateral groove. This is a normal arterial artifact, and we see it all the time. You'll see these little divots in the lateral biceps groove, and you should not confuse these little divots as pathology. These are not ligament avulsions, for example. These are nutrient foramen, and they are normal, and we will see if you turn on your color power Doppler or even just your regular directional Doppler feature, you will see that these are normal vascular insertions into the cortex. So moving forward, let's talk about scanning the biceps tendon just a little bit more distal. And here you can see we've isolated the pectoralis, or the pec major here, and you can see the anatomy diagram from the clavicle all the way across the sternum. We see this huge, broad muscle tapering down to one smaller tendon origin, and that is, or insertion, I should say. It's very broad. If we cut that transversely, we'll see this big, broad tendon. But as a landmark for this exam, this kind of tells us where we can stop scanning for the biceps. So as we leave the biceps groove, we traverse down to the pectoralis, and unless pathology or clinically indicated, there's really no need to go further distal. But what we're seeing here in an internal and external rotation is that long head of the biceps is right under my mouse. The short head of the biceps is here under my mouse. And then we have the coracobrachialis right here, deep to both of those. So cross-sectionally, we're seeing that musculotendinous portion of the biceps here, tucked underneath this wedge of the humerus and the pectoralis. And it's at that point that we can stop exploring the biceps for pathology, unless clinically indicated to go further distal, like a distal biceps tendon rupture or a Popeye sign, for example. Turning the transducer 90 degrees to longitudinal orientation, we see these longitudinally oriented tendon fibers, and here we can beautifully see why these tendons really respond to angle artifact or anisotropic artifact. They are longitudinally arranged, linear, fairly parallel, and that is all the makings of angle artifact and what we look for in a healthy tendon. But we can see the anterior humerus here. If you're not seeing the biceps tendon, we'll go over this in the live scan next, but you'll want to pan the transducer medially towards the coracoid or laterally towards the greater tuberosity. If you're going further medial, you'll see this humerus disappear. And if you're going further laterally, you'll see the humerus elongate to more of that surgical neck of the humerus. But here's the long axis of the biceps. The musculotendinous portion is here, and the pectoralis major is also about this level. So we're going to keep moving forward to the subscapularis. So in the subscap exam, basically what we're looking at is another large muscular structure tapering down to a smaller tendon at its insertion on the lesser tuberosity of the humerus here. So here on the grayscale, we have the lesser tuberosity looking like a bird's beak. This was taught to me that birds have long pointed beaks, and we get around to the supraspinatus tendon on the lateral shoulder. Later in the month, it has a parrot's beak, or more of a hooked bill, more prominent greater tuberosity. So this lesser tuberosity is relatively flat, and that's how you can kind of tell the difference of which tuberosity you're on here. Here we have an anterior and a middle deltoid, or lateral deltoid, and then sometimes there's a deltoid septation here that can cast a shadow into the tendon, and you're going to want to be mindful of that artifact as well. But this is a great exam to do dynamically, and we will in the live demonstration. Your patients will love it because it really puts the shoulder into motion, and it makes this all really fun to do when you're seeing the tendons glide with the muscles. Turning short axis now, 90 degrees. We're going to rotate the transducer. It looks like a long axis biceps, but we still have the arm externally rotated here. So that's really important. I failed to mention that on the last slide, but what really brings this tendon out to you is that you get to keep the transducer stationary from the biceps exam and just externally rotate the shoulder, and you end up with a beautiful subscapularis tendon. So here we are in short axis, and I'm cutting these tendon fibers. This very wide breadth of the subscapularis tendon has all these little interdigitating tendon slips. Don't confuse these for pathology. These dark hypoechoic areas are normal. They should be there. They are just the spaces between the tendons, the ligamentous kind of bands between the 3, sometimes 4 broad tendon bodies that that all make up the subscapularis. So as we pan laterally, this will taper to something thinner. As we go more medial towards the coracoid, we'll have to aim laterally, and we'll do that also in the live demonstration. But that should conclude the last slide, and now we'll just transition over to the live demonstration. One moment. Okay, so now we'll start scanning the anterior shoulder. And first, I'm just going to adjust the machine. I've already kind of got it where I like it for height. There's a little foot pedal here at the bottom, but it does go down lower if you want to be seated. A lot of people will be seated in an adjacent stool and scanning this way, but I find it to be a really cool exam to show the patient. So I like to scan standing next to the patient back here. And I'll go ahead and just, it's kind of like adjusting your mirrors in a car. Find the right angle. We get that chance with this tiltable hybrid form factor here with the Sonocyte PX. So instead of it being in a clamshell configuration like this, I kind of like those touch keys to all face me so that I'm comfortable. But in this configuration, also the patient gets to see the monitor too. So I like to scan this way. Because I'm left-handed. If you're right-handed, you would just put the machine on the other side and turn, or you would also have to face the opposite way. But for today, I'm going to be scanning right here. I like to rest my hand on the top of the shoulder for support, and let's start scanning. All right, so I've got the thumb orientation marker going to face the patient's right. Okay, so what I'm going to do is just turn and have that facing me in this case, or lateral. And I've got the patient positioned with the palm up in the lap. And a really cool scanning tip or pearl here is that as long as that palm is face up, it's pointing the elbow anterior, right? Those epicondyles are also facing anterior. So the medial and lateral epicondyles are kind of representative of where the biceps groove is. So the biceps groove will be right in line with the anterior elbow. Obviously, we don't hold the transducer like this, but this is just to give you an idea of where we are. I imagine the humeral head is this ball, and I have to stay 90 degrees to the surface of the ball. So if I scan inferiorly, I have to point up. If I scan superiorly, I have to point down. Step 2 is just to make sure I have a really nice sharp cortex. So I'm kind of ignoring all the soft tissues for now, but I'm really focusing on the cortex of the lesser tuberosity medially and the greater tuberosity laterally. If your cortex is fuzzy like this, it's not sharp and defined, then all your other soft tissues on top will also be fuzzy and not sharp or defined. So we're not hitting those at 90 degrees. But all these connective tissues and tendons are wrapping around the surface of that ball, and we want to stay 90 degrees to the surface of the ball as well. So with that said, we're going to demonstrate this anisotropic artifact that we discussed in the slides. So here we have the biceps groove at its deepest point, lesser tuberosity, greater tuberosity. Here's the biceps. In a lot of your patients, there's going to be a lot of scar tissue in here, and this biceps can really blend with a lot of surrounding connective tissue. So sometimes you can use the anisotropic artifact to your advantage. So I'm just going to tilt the handle up and down and demonstrate that only the biceps tendon is going to turn dark there. So this one sliver here, that's biceps, not necessarily this outer edge. So this is very likely to be a part of the biceps tendon sheath right there. So there I am at 90 degrees. Here I am using the anisotropic artifact to define where the biceps tendon begins and ends. So transversely, I'm going to scan distally now, as we discussed in the slides, down to the pec major. I'm just going to keep following that tendon. If I get the tendon lost because I didn't stay 90 degrees to the tendon, that happens a lot as soon as you fall off. If you don't drop the handle of the transducer and you just remain 90 degrees to the surface of the skin, watch the biceps tendon disappear into the deltoid almost there. So if you're just learning this, all of a sudden our really nice oval of the biceps just looks like another fascicle of the deltoid. So it's here, but it's it's really blended in with the rest of these fibers. That's why it's important to imagine that we're scanning the surface of a ball, and that as we scan distally, we have to aim the beam proximally. Here we go. So let's follow this biceps tendon distally, distally, distally to the pec major. So here we have the pectoralis. We have the biceps long head here, little septum here, biceps short head, and then we have deeper coracobrachialis. Lost my arrow. Down here. So short head, long head, coracobrachialis, pec major. We've gone far enough. So now we're going to go proximally, and we're going to follow this biceps tendon right back up to its groove. Here we go. And now what we're going to do is just take the transducer and go long axis. I'm going to bring the proximal, the left side of the screen, proximal, and I'm going to rotate. There's nothing wrong with grabbing the transducer with two hands. I do that all the time. So I'm going to keep this hand right where it is, and I'm just going to use this other hand to pivot this way. Now, right away, I see nothing but greater tuberosity, right? Like all of this is just humerus down to the humeral neck, and I know I'm on the greater tuberosity side for a few reasons. I see a little bit of the bird's beak that would represent where the supraspinatus begins, or I should say ends. But if you're too medial, we're going to cross over the biceps here, and then we're going to go medial. If you're too far medial, all we see is lesser tuberosity, this bony peak. So in short and long axis, it's a bony peak. So I'm going to see lesser tuberosity, and then the humerus takes a sharp dive off the screen. So we really lose a lot of humerus when we're scanning medial, or if we're too medial. For the sake of zoom here, I'm going to adjust a little bit of the gain, noticing that we could afford a little bit of brightness there for the broadcast. Here we go. So now I'm going to go back to the center of the groove there. Biceps tendon is in its long axis. Again, if I stay 90 degrees to the surface of the skin, you notice that the tendon dives away from the probe, and it's dark. Here's the tendon. Now, there's nothing wrong with the tendon. It's not tendinosis or anything. I just need to make sure I'm staying 90 degrees to the tendon and not the skin. So I'm going to drop this handle down just like we did in short axis. I'm going to level the transducer out with the biceps tendon. I might even come up in my depth a little bit so we get a bigger, more clear image. And let me outline the biceps. So this is the long head of the biceps. We didn't cover it in the PowerPoint. The short head is attaching to the coracoid. So if I come over here and palpate the coracoid and just bring my transducer over to the coracoid, here's our coracoid and short head of the biceps attaching on the coracoid. So we talk about a long and a short head. Here's your coracoid, here's your short head, or coracobrachialis here, short head of the biceps on top. Let's go back over to the humerus. There we go. I'm going to follow this tendon distally to its myotendinous junction here, and you can see the fibers of the biceps at its muscle belly starting to fan out, and even superficially we see the pec major starting to jump over very, very thin right there from here to here, even further down, the pec major tendon. So here's the end of the pec major tendon here, here's the beginning of the pec major tendon, and then here's all the biceps brachii fanning out. So let's go back up proximally. We see some what look like fluid collections here. And let's see if those are actually fluid collections or if they are the vessels that we talked about in the PowerPoint. So I believe these are the ascending branches of that lateral circumflex humeral artery. So I'm going to hit the color button and just put the box right over. And we see pulsatile arterial flow. Don't even have to switch over to color power Doppler. And I bet if we follow the lateral side of the tendon, we'll see this really cool elongated artery coming all the way up into the proximal groove, and we'll see that artery diving right into the humeral head, just like we talked about in the PowerPoint. And that is a nutrient foramen where these vessels are coming out and feeding these soft tissues into the cortex. So if I go short axis, just like we saw in the PowerPoint, you're going to see the lateral groove. It's going to show that ascending branch of the lateral circumflex humeral again. If you don't see it on your machine, consider just tilting down the groove So you're going to make a real ugly tendon. When you make an ugly tendon, you get a really nice vessel. So here we have a nice artery and a really ugly biceps tendon. And that's kind of the trick to scanning the groove and its contents. But everybody has these little nutrient foramen here. Do not call those avulsions of the coracohumeral ligament. These are nutrient foramen, and I've seen them called avulsions quite often. So these are pretty normal on everybody, and I would challenge you to go ahead and test that out at home if you have a machine with you, and see if maybe you can pick up those small vessels on your machine. All right, so with this position here, we're just going to transition to the subscapularis. This transition is really nice because all we have to do is just find our biceps here in the middle of the groove. And then this time, what I'm going to do is just have our patient externally rotate her arm. There we go. And there we see the subscapularis delivers out to us. We don't even have to move the transducer at all. So we want to scan superiorly and inferiorly. And remember, we're scanning a ball. So as I scan superiorly, I have to aim down. And as I scan inferiorly, I have to aim up to get the tendon at 90 degrees. So I'm starting at the top of the ball. Here we can see biceps right there where the arrow is. And we can see subscapularis here. If I go rotate the transducer more elongated to the subscap. And I'm at the superior margin of the subscap, so I'm entering the rotator cuff interval just about. And now what I'm going to do is scan down. I'm going to go down. And as I go down, I'm going to lose the subscap because I did not aim back up. So now I'm going to aim up. Here we go. And I can see it really, really nice. Now, as you go superiorly, don't forget to bring the medial side of the probe over here to the coracoid process and check for that subcoracoid impingement. So here we can do that dynamic maneuver. Sometimes it helps to passively rotate so that the patient doesn't contract any muscles that may distract what we're trying to look at. So it's better sometimes for you to grab the patient's arm and just go ahead and warn them that, hey, we're going to put your arm into some stress. I may ask you to push and pull just to get these soft tissues moving in a way that we can see everything that's going on there. But what I'm looking for is this space right here underneath the coracoid. So we have coracoid shadow here, subscapularis. You see the subacromial bursal layer up here. As we get down here to the subcoracoid area, we enter the subcoracoid bursa there. And what we're going to do is look for impingement. And as she internally rotates, I want to see and make sure that that biceps tendon and its lesser tuberosity have plenty of room to clear lesser tuberosity to coracoid, and that I don't see any grinding or popping or clicking or adhesions showing themselves there. So we see a good smooth action there. And just scanning, what I am noticing I'm having to do is point the medial side of the probe pretty far north, pretty far cephalad, and the lateral part of the probe pretty far inferiorly to get that long axis subscap to show itself during this maneuver. After we've done that evaluation across the footprint, I like to keep the footprint in the middle of the screen, and I'm going to do the same two-handed switch. So I'm going to rotate with the top part of the probe here. And there we have the lesser tuberosity and short axis here. If I go further lateral, I'm just going to rotate the chair for the camera. If I go further lateral, you're going to see the biceps tendon in its groove. Just to give you an idea where we are, here's the biceps tendon, long axis. I'm going to climb up the lesser tuberosity's peak and up and over, staying 90 degrees to the surface of the cortex. And there we can see those interdigitated fibers of the subscapularis. And these little dark components in between, these are not pathology. These are the little tendinous slips that make up the space, the connective tissue space, almost like a ligament, between each major head of the subscap. So we have 1, 2, 3, sometimes there's 4. Then we get into the rotator cuff interval anatomy, like the coracohumeral ligament, the superior glenohumeral ligament complex, which we'll talk about on the lateral shoulder webinar. So subscap, really cool scanning trip is taught by my friend Bill, is to go from the humeral head surface and bring the transducer all the way over here to the coracoid. So locate the coracoid, just like we are here. Hopefully you can see that on the camera okay. Give yourself a little bit of depth. And I'm just going to keep my probe at the coracoid level And I'm going to tilt the tail of the probe towards the chest. And that's going to fire the beam laterally. And it gives you this beautiful shot right there of a transverse subscapularis tendon right there on the humeral head every time. So this is really nice. It gives you the right angle you need to evaluate this cartilage on the humeral head. You can see that articular hyaline cartilage cap just beautifully resting on the cortex of the humeral head. So we will just keep tracing distally until we see these cortical margins come up to the tendon at a tapering edge, and then we start to see the biceps here. And we've evaluated the entire subscapularis tendon at this point. If we do more of an external rotation, we'll get more muscle in view. So there's muscle where the arrow is, and then here's tendon. So muscle, tendon. All right. So that will conclude what we covered on the PowerPoint, at least for the live demonstration. Now's the time to go ahead and log those questions in the Q&A portal, and we'll get started on answering those questions live as they come in. Otherwise, I'm just going to keep scanning.
Okay. All right, so we've met the live portion of the Q&A. So if you do have a question about anything that we scanned, feel free to type that in the chat. We're able to see the YouTube comments just fine, but we can't guarantee that there's not a delay on the YouTube portion. So the best thing to do is to do the chat in the actual Zoom webinar, and we can see those questions immediately. Usually, questions we get sometimes are injection approaches. We will have webinars that are dedicated to procedures throughout 2024, so stay tuned for that spring and summer schedule. Let's turn down the gain a little bit. There we go. When it comes to the anterior shoulder, I think this is the most recognizable landmark, so that's why we want to start there, is the biceps groove. And if there's anything that you could even share with us in the comments that has helped you learn the shoulder, help your peers and colleagues out. We've got a lot of viewers here that joined tonight, and the recording will stay on the YouTube channel, and it should subsequently be posted in the playlists that are coming up. So feel free to comment. We'll get to your questions. If you enjoyed the presentation, be sure to share that feedback with us. We're here to help you, and we're going to have several of these throughout the next few months. So next week, for example, we're having one Tuesday, which is December 11th. Actually, not 11th. That would be December 18th, I think it is, Tuesday. And then in January, we'll start up January 11th, and then we'll have another one the week after that. So we're going to have about every 2 weeks or so be looking for another webinar until we wrap up this shoulder series. But today's the anterior shoulder. The next one next week will be on the lateral shoulder, and we're going to cover the rotator cuff structures. So we'll get into the supraspinatus, we'll get into the impingement maneuvers, we'll get into the common rotator cuff tears and scanning techniques. And I think what you get out of these most, out of anything else, is we're going to be sharing scanning techniques, the how-tos, the subtle transducer movements, and those are the things that are kind of hard to get. Scanning pearls, sometimes at workshops you don't have a lot of time to ask questions if there's a group or a crowd around the machine. So this is your time to ask those questions if you have any. And as a lot of these go, we might get one or two questions, and that's totally fine too. Keep your eye on the YouTube channel as we monitor that in the future. I'll get on and answer your questions over chat as time permits. If you have any questions about anything you saw here product-wise, that's fair game as well. If you have any questions about the musculoskeletal startup for your practice, as far as adding ultrasound goes and Sonosite products and what that means to join Sonosite as a partner, feel free to email me at daniel.shelton@fujifilm.com. and we'll get right back to you. I'll make sure I put you in touch with the right person, whether that be education related, whether that be sales related. We just want to make sure that you're taken care of and pointed to the right person. So you could just message me over email too if it's something that you don't want to ask a question in a live chat. I totally understand that too. We'll just give it another minute for the chat. I'll keep scanning because it's kind of fun. And what I find to be a lot of fun actually is the color Doppler of the biceps groove. As I mentioned in that PowerPoint, way too often I see that divot right there called an avulsion. And if you go short axis, it's lateral to the groove, and just about everybody's got one. And if you ever question whether or not that's an avulsion right there, that deep spot, or if you're in the arthritis world, is that an erosion even? That's a question that we get a lot of times. Check the other side and see if the patient has that big deep divot bilaterally. We do have another comment here. Short axis view of the biceps groove. What's the name of the maneuver to eliminate the anisotropy? I don't know that I know the name of the maneuver that would eliminate the anisotropy except to tilt. You know, this is wagging the tail. It's not heel toe. If I was long axis, this would be considered with the heel, the distal portion of the probe, and this would be considered the toe. So this would be a heel toe maneuver. But when you're in short axis, I think it's just considered a tilt. So this would be a short axis tilt to make that biceps either appear or disappear. But that's a great question. But the big key thing that when we're teaching, especially beginners, is knowing that angular artifact exists. It exists on longitudinally arranged, linear oriented fibers. So you don't see this so much in fascia as much. You don't see it in disorganized fat. You see it a little less in muscle because there's so much fluid content in the muscle and so much more fascia interspacing those fascicles. You see it less in nerves because we have nerve fascicles insulated with fatty epineurium around those, kind of like a cut in half extension cord. So the more dense the fibers are packed, like a ligament, the more anisotropy. The more loose the fibers, like a muscle, the less anisotropy. So you can just kind of grade it and what to expect when you're scanning these structures on your own. So a biceps tendon is going to be more anisotropic than a muscle that's sitting above it, like the deltoid up there. Even though if you hit the deltoid just right, it will shine back really nice and bright, depending on how lean the fibers are. And that's one other thing to take into consideration is the quality of the tissue you're scanning. So if your patient is a little thicker than our model here today or has diabetes, for example, it makes the muscle less echogenic. So we have a nice, healthy, fluid-filled muscle here today, but if your muscle is less water-filled and it's more oil-rich, like fatty atrophy, as these muscles degenerate and become more oily, that scatters our ultrasound wave a little bit more, and we can't see through the muscle as clean. It's less transmission, so you get this dirty, scattered echo. It may be, you know, a lot of people get frustrated. Is it my machine? Is it my settings on the machine? And sometimes it's just the quality of the tissue you're scanning. It could be a bigger part of their clinical makeup. But anisotropy is the biggest topic in all of musculoskeletal ultrasound. It's because we live in an isotropic tissue relative to a homogeneous or a heterogeneous. We live in an isotropic or an angle-dependent tissue in MSK. So longitudinally arranged linear fibers, as they dive away from the probe, you can see that biceps tendon is very dark. And I'm losing a little gel contact. Gel makes your image better 100%. So anytime you just add gel, if you don't feel like you have the image, just add some gel. It's great. We've got another comment there. It says that it appears the short axis view of the body. Here it is at the same one. I think we answered that one. Okay. This is a new one. Whoops. It appears short axis view of the biceps is the long axis view of the subscap and vice versa. And the position of the patient for both muscles is the same. So the position of the patient is the palm up in the lap. And you're right, the long axis bicep goes perpendicular to the subscap. And when you're in a short axis biceps groove, and that's what I'm going to say, a biceps groove is very important to distinguish here. So let's get our arrow back up here. There we go. When the groove is its deepest, right here, that's when the lesser tuberosity is more prominent, and that's when you can expect to see subscap be attaching. So we're going to have our patient externally rotate, and we see the subscap come to us in long axis. Absolutely true. Perfect. So when she relaxes and comes back to her lap, there we go. Say I was a little bit lower off the groove, but still near the humerus. If she externally rotates, we're into a few other structures. Don't confuse what's deep down there as subscap. So we're starting to enter subteres minor and latissimus dorsi territory down there. So those are not subscap. And then down to pec. So here's pec major, latissimus dorsi, shadow, this thin little guy here, rides on top of teres major. So we talk about teres minor all the time in the posterior shoulder, and we'll get to that. But you don't want to confuse this guy further south as subscap. So we've left the subscap, and we're down at the teres major and the latissimus dorsi before we hit pec there. So any of your reaching injuries on your athletes that reach and pull, they can actually avulse that segment just south of the biceps and cause a little injury right under the biceps, which might be a pain generator. Just one more thing to look at. So now, as I mentioned, that scanning tip, the probe right here is following the anterior elbow. So you got the medial and lateral epicondyle, and you see that the transducer handle is relatively following the forearm. So that's the trick for following the biceps groove. So I'm going to have her internally rotate, but I'll chase the biceps with the handle of the transducer, and then externally rotate. So if you're doing a dynamic maneuver, trying to see if that biceps is going to dislocate, all you really need to remember is to follow the forearm with your transducer, and you can do pretty cool dynamic maneuvers that way. All right, let's go ahead and relax. All right, so we've given it just a few minutes. And typically in these meetings, we might end up with 2 or 3 questions, just like we did tonight. I'm going to give you guys the rest of the night to kind of think over any questions you might have. Again, feel free to email me, contact me, daniel.shelton@fujifilm.com, and I'll follow up with you about the webinar, anything that you saw here or didn't see, and maybe even consider adding it to future webinar content. But we appreciate everybody that came out tonight. We're going to call that a wrap and close this one out, and just be prepared next week for the lateral shoulder. It's got more meat to it: supraspinatus, infraspinatus, subacromial bursa, dynamic impingement maneuvers. Probably, the highlight of the whole shoulder exam is in the lateral shoulder, so don't miss that. Thanks, everybody. We're going to call it a night. Thank you.